My name's Mark Magnuson. I'm the immediate past president of the Australasian Society of Aesthetic Plastic Surgeons, coming to you live on Facebook through the Plastic Surgery Forum for Aussie Chicks. And tonight we're going to talk about Brazilian butt lift, or BBL. For those who have been following the news recently, will have seen that it has hit the news. The main concern for us as the societies is the safety of patients. A recent study in America, which has combined the work from the American Society of Plastic Surgeons, the American Society of Aesthetic Plastic Surgeons, and the International Society of Aesthetic Plastic Surgeons. All plastic surgery societies have a combined task force. They looked into this and they found that the mortality rate is 1 in 3,000. So that's quite alarming. The normal mortality rate for this sort of for cosmetic surgery would be more like 1 in 80,000 or something like that. So that's a worrying problem. What becomes really worrying is that a lot of these deaths occur when in clinics where the training isn't what we would call appropriate, that it's not core-based plastic surgery. And the problem is that something like BBL is riding on a wave of Insta fame. It's become popular. It's getting promoted in a way that makes it seem more like a haircut or something that's not surgical, rather than something with a surgical that is a full surgical procedure with risks and benefits. So the question is, why is this such a risky procedure? And if we look at the buttock and look at what's happening, what we see is that inside the buttock, deep to the muscles, are large veins which come out of the pelvis into the leg, and going back the other way into the body, they're a direct route back to the heart. So there are two main theories as to how this has happened. One is that the volume of fat put into the vessels is put deep into the muscles. It gets below the muscles around these veins, and with a tear in the muscle, or the tear in the vein, because they've only got very thin walls, the fat can be put straight into the vein. And every single patient who has died of this procedure has fat both in the muscles and in the veins. One of the more recent theories, in fact, is that it doesn't have to necessarily be injected directly into the fat, but if there's deep fat in that area with a little laceration of a vein, as everything expands up in volume and opens up these vessels, there's a siphon effect that can draw the fat in. The common problem or common issue is fat in the deep plane within the muscle, and it goes off to the heart as fat emboli, and that leads to blockage of the blood flow through the heart and what we call electromechanical dissociation. This has been known for a while, has been looked at for a while, and there are a number of safety measures that have been suggested by our international societies, and there are a number of things we know about how to make this procedure as safe as possible. So one of the first things is that one of the most important things is to have someone that is properly trained in all aspects of surgery and is appropriately trained in liposuction and has a very deep knowledge of the anatomy in this area and an understanding of the concepts which can make this a safer procedure. Within the buttock, there are safe zones and there are unsafe zones. So what has happened over the last few years is we've focused more on making sure that the fat going into the buttock is going into the right places and the right plane. So the injections are going superficial into the fat above the muscle. That's something we've known for quite a while. We're focusing on safe areas in the buttock so that areas where the veins aren't present, so that we can fill those areas in a way that improves shape but doesn't greatly enhance the risk of this procedure. So, for example, if we look at a buttock, and you've got to use your imagination here now, it's often this outside part of the buttock which is losing its volume. Okay, so if we look down the middle, this part in the middle, okay, so if we divide it into half like this part in the middle is our danger zone. But the area where we're losing the fat and is interfering with the shape of the bottom is actually a relatively safe zone. So what we're doing is trying to get, well, I'm going in the wrong direction, a round shape that way. I'll get this right shortly. We want to fill up this zone out here to make it a nice rounder bottom at the bottom rather than pinched. So we talk about shapes of the buttock. We talk about the ideal shape being something like an A shape, not quite, but close. There are other shapes like round or square and V shape, where we get loss of that volume at the bottom and the outsides. So what we're trying to do when we do this procedure is fill those safe areas. And one of the most important things is that it's as much about what you're taking away as what you're putting back. So it's those distracting collections of fat in the love handle or the muffin top region in the lower back. So we're doing liposuction to remove the distracting fat, and then we're putting volume into those areas which are going to enhance the shape and the firmness of the bottom. So there are lots of good reasons for considering it, but there are a lot of important elements. So one of the techniques which is being talked about a lot now is called, well, it's got an interesting acronym. It's EVL, EVL, which stands for expansion vibration liposuction. So when we do this, one of the safety things, we're not using in general we're not trying to use very small cannulas like we would for fat grafting into the face or the breast. We're using broad, wider cannulas, something that's about 4 millimeters in width or greater. We're using something that might have a basket on the end, so as it pushes through, it separates the tissues, and the fat's getting pumped back through the cannula that we're using. So we're creating space, the fat goes in as we're going along, and by using a broad cannula, we're not getting, it's too broad to actually cannulate those vessels. But the other thing is that it's moving continuously. And because we've got the larger cannulas, they're quite stiff, so it allows us to control the position of that tip of the cannula, to keep it in the subcutaneous plane. We can keep it, we can get them long enough to push us into those areas of that we want to address and avoid the ones we don't. But also we can use access points in a different location that keep us safe. So an access point in the gluteal cleft, for instance, we can't physically get around the pelvis and down to the deep position where those veins are. So that gives us an element of safety as well, which safeguards even a good technique. It makes it an anatomical impossibility. The other thing is we're looking at not just the buttock, but we're looking at those areas around the buttock, such as the hip dip region, that area just below the pelvis on the outside of the buttock, where we get a buttock that pinches in, gives the boy bottom appearance. So these areas are, again, safer zones, which when filled and enhanced, contribute greatly to the shape of the bottom, but in a safe way. Finally, we find that there's now a tendency to move away from large volume. A lot of what we see on Instagram, and particularly out of America and South America, is very large and very exaggerated forms. And that's an important thing, because those are the conditions which can lead to a greater risk for things like the siphon effect, which may be one of the ways in which the fat emboli is occurring. And so what we see now is increasingly that the conscientious and and properly trained practitioners are moving towards limiting how much fat they're going to put into the buttock in one setting. So when someone does, for instance, ask for quite a substantial enhancement, there's a trend for some people to say, well, we can only do a certain amount safely at one time, and if we're going to do more than that, you may need to do procedures. But there's a substantial amount of change that comes from taking down the distracting areas and filling the appropriate areas, and when it's done properly, those more modest volumes of fat go a very long way. Because the most important thing is that this procedure, which can be phenomenal in how it looks and the outcomes we get, must be done safely, because 1 in 3,000 risk is completely unacceptable. Now, we did get a couple of little questions before. I'm just going to have a look at them just so that we can give you an answer. So some of these questions relate to how long does it last, and that's fat grafting the body. Now, when the body weight gains or loses, so we gain weight or lose weight, within normal sort of ranges in the overweight range, what happens is we have fat cells, okay, and they're like sultanas. Okay, so when you're slim, they're pretty small, and when you gain weight, they become more like a grape, so they expand. We don't get new fat cells. So what's happening when we do liposuction, for example, we're taking away fat cells from a certain area, which means that as you gain and lose weight in future, less goes to that area. So we do it to either distracting zones or areas where there are familial deposits. You know, some people might have bigger legs or a bigger bottom or a bigger tummy and small leg and so forth. So this runs in the family, but when we treat those areas with liposuction, we reduce the proportion of the body weight that goes to that area. So it's an effect, although it's designed to have the maximum effect at the weight at which the surgery is done, there is still an effect that is there when you gain or lose weight. So that element is permanent. The same thing happens with fat grafting, which is what we're talking about. So we put the fat back into an area like the face, like the breast, like the buttock. And what will happen is we put the volume in, we'll get swelling. So that increases the apparent success of the operation. The swelling will go over 6 weeks or so. And then over 6 months, a proportion of the fat will also not survive. So typically we talk about two-thirds, half to two-thirds of the fat survives permanently. Now, it can be more successful depending on how you're using and processing the fat. It can be less successful, and certainly things in the recovery will interfere with outcomes. So you don't want to have too much direct pressure on the buttock. And that's one of the questions we often get, you know, how long before I can sit on my bottom? Certainly we find that a lot of practitioners use a BBL pillow, and you can look online, you see a whole bunch of things on that. And basically what I use in my clinic is a bit of foam rubber from Clark Rubber. It's quite thick. It's about 3 inches thick or 7.5 centimetres thick, and we cut it out like an egg cup, so that when you're sitting in that, you get an even pressure around the bottom rather than direct pressure on certain areas, which might lead to flat zones. So this gives us more even and more gradual pressure. The best positions when you're sleeping are on your side and on your tummy. That's a difficult problem for some people, as they also find out when they have breast enlargements. If you're used to sleeping on your tummy and you're recovering from breast surgery, sleeping on your back is not necessarily the most comfortable thing, but it is certainly the best thing for the fat. If one of the other problems with high volume liposuction, fat grafting into the buttock, is that when we're doing it, the idea is that we're putting little globules in lots of different areas so that there's normal tissue around it, which gives good vascularity and makes the fat survive as well as possible. Certainly it has been seen and identified that some people will put it in great big blobs, and that doesn't allow the fat to heal in that sort of circumstance. So you can get fat necrosis. It is interesting, though, that in the buttock, fat necrosis doesn't seem to, despite the fact we're putting in quite a bit of fat into the buttock compared to what we do into the face or the breast, fat grafting is not terribly apparent. But certainly some areas of fat, that third of the fat that doesn't survive, does undergo fat necrosis. It is possible to get little cysts where fat cells have died, release their oil, and the body makes a little cyst around that. But more in that realm of sort of overshooting realistic goals and safe technique. But certainly it is something that's there. The scarring in the buttocks, like anywhere else in the body, can alter how much the tissue can expand. So if you've got scarring, I see patients sometimes who've had a lot of injections in their buttock. They might have had extensive stays in hospitals, a younger person, and end up with some scarring in the buttock or something like that, or trauma. Those sorts of things don't expand as reliably when we're trying to expand it with something soft like fat without a surgical excision and a surgical release. But certainly it is something that is used. And one example is someone who's had hip surgery, a hip replacement or a fractured hip, and you can get contour changes that exacerbate that hip dip deformity we see on the side of the leg or the buttock after hip surgery uncommonly. So it certainly is something that is applied not just for aesthetic purposes, like most cosmetic procedures. They start from reliable reconstructive surgery that's performed in a way that becomes so reliable that we can expand the applications into areas where we're dealing with something that's normal and trying to make it better, rather than just dealing with deformities and cancer and so forth. So this is like others. It started particularly in the breast. It's been used in the face for a long time. We understand what the benefits of fat grafting are, even though we don't fully understand how it occurs. Just like in the breast, into the buttock, this has been a reliable reconstructive procedure that we can now bring into the cosmetic surgery realm. This is why plastic surgery training is one of the paramounts to good cosmetic surgery, because we have that depth of experience and training from the genesis of these newer techniques, the application in all these other areas where we use them all the time, and then get them to a point where they're so reliable we can use them in the plastics for cosmetic surgery patients. So certainly maintenance of the fat once it's survived is an ongoing thing. It's just there, it's just fat. As long as we get through that first period, and we do have activity restrictions. A lot of us will say, no exercise really apart from walking around doing what you have to do for the first week, light walking for the second week, and building up slowly. But it's 6 weeks before you're liberated with respect to activities, particularly for anything that requires sitting. And in my clinic, we use the cushion, the support of the buttock for 4 weeks in that process. Interesting question, can it be reversed? No, once the fat's survived, the fat's there. We do have techniques for removing fat. They're injectable techniques like we use particularly under the chin. There are liposuction tools and so forth, but that's not something that improves the buttock generally. If you take fat away from the bottom, it becomes more saggy and less supported and more irregularities in the tissue. So that in itself is a very good reason to keep the goals of this sort of surgery realistic. We see a lot of images on Instagram that look alarming, great big bottoms, tiny, tiny waists, and these are going to be permanent problems or permanent shapes. 10 years ago, everyone was talking about a small bottom. We got this expansion and we've gone to big bottoms, and now there's a sensible drawback to shaped bottoms. We see the same thing when any new technique or any new device is introduced. Lasers first started getting used extensively in plastic surgery and dermatology in the 90s especially. All of a sudden a laser was used for everything. And we've got to a point where the lasers were used in ways that we found out they weren't reliable, they were causing problems, or we developed different types of lasers which became safer. There has been a trend for very large breast implants, and that's pulling back to focus more on shape and appropriate and proportional enlargement. Smaller implants give us fewer problems. We're also seeing a trend towards composite breasts, so an implant and perhaps with fat as well, which might either improve the cleavage for someone who's got very little cleavage, be used for someone who's got a tuberous breast or a breast deformity or a chest wall deformity, to combine implants with fat to give us an even better outcome than the implant alone might perform. And in revision of implants, we're seeing a trend that's developing overseas. It's been championed in a few areas, particularly in France and in Japan, where if we have, say, a 350cc implant, it needs revision. At that revision, the implant might come out, a smaller implant go in combination with fat grafting. So that we end up with similar volume but more fat and less implant, because we know implants don't last forever. And over a subsequent period of a couple of these procedures, we can even get to the point potentially where we have a similar outcome but with fat alone. So if I were to predict where we are in 5 or 10 years, then I would think that that's where we are. And already in my clinic and in a lot of my colleagues, they're starting to look at transitioning from implant to implant plus fat, and that at a further operation later on might be more implant, smaller implant again, or no implant and fat again. And certainly we do this in implant removal cases also. So we've got to try and keep it real. We've got to try and keep it safe. So the Australian Society of Aesthetic Plastic Surgeons is taking this real. We've seen tragedies. You know, we saw the poor lady in Sydney last year who died when she was having her breast injected with illegal fillers by someone who wasn't a doctor, and she died from that process. We've seen in April this year, we've seen someone go blind from fillers to the nose. We know that this is the riskiest operation in plastic surgery. The risk of 1 in 3,000 is higher than the risk of going blind. The real concern is that if this is just managed as a trend where you have clinics who might be promoting it because they see that in the short term, this is somewhere where they can get busy, they might make some money, that alone is not a reason to do this, okay? It has to be done properly. It has to be done in proper hospitals. It has to be done with proper anaesthetic cover. It has to be done with fully qualified, fully trained plastic surgeons who understand the anatomy, the risks, and all of these task force findings that we're putting out and sharing with our members. It can be done well. It can be beautiful outcomes. And, you know, I've heard it said that the bottom is the new breast. And there's no doubt that a shapely bottom can be very beautiful. But it absolutely needs to be done properly. And it absolutely needs to be done safely. So, look, if anyone wants to put a question up, that'd be great. But look, we will be advertising the findings of our task force. It's being run by Tim Papadopoulos, who's one of the past presidents of our society. It's something that we've recently, our society, you know, the Australian Society of Aesthetic Plastic Surgeons has 5 or 6 educational meetings each year. This year we had one that focused precisely on liposuction, fat grafting, the safety, the science, how best to get these techniques, and that was run in association with our annual meeting only a couple of weeks ago. And it was leading up to that when we had discussions and said we need to actually really create this task force and look into it. And it's absolutely critical that we get ahead of this problem and get some sort of knowledge and hopefully regulation out there about this problem before waiting for that complication which we so dread and don't want to see. So it's all about safety first. It's about proper qualifications rather than fake qualifications. It's about making sure that we get reliable reliable outcomes for patients in a safe way. So, look, thank you for listening, and I hope you've all had a good night. I hope you continue to have a good night. And if you have any questions, I'm sure Trish will be able to get them back to me anyway, and feed them back if they're important for you to be answered. Thanks so much.